So much for the opportunity to present to you today. We have been working on the RAHC program now for since March, so I don't even know how many months that is. It's going by so quickly, and we have had the wonderful pleasure of working together with various stakeholders across the state, and the number just keeps growing. So really excited to see where this work goes. But just to give a little introduction, the RAHCs have been established by DHS as part of their whole person care roadmap. So what is that need to bring together the various services we have, healthcare services, mental health services, community-based services? How can we start to integrate these different pieces together with a community-led approach and really focus on addressing social determinants of health, reduction of health disparities, and in doing so, promote health equity and value in healthcare? And so you can see here our goals listed. I won't read through them specifically, but really our intent is to identify those communities of greatest need across the state. So we have identified it was initially called the Montgomery Chester zone, and we've now really focused that in on Norristown and Pottstown. And how can we start to look at these communities and understand what are those social determinants of health that are really driving poor health outcomes? How can we start to work together with our varying silos and breaking down those barriers to improve care delivery in these communities? And how can we really support and steer population health through improvement processes as we go along? So a really wonderful opportunity. We actually have probably close to 500 stakeholders now who have been engaged in this work, knowing that most of the people on these calls are just so desperate for the opportunity to finally integrate these services and have that greater impact, which I know this council really works towards. And what we did to identify these areas of greatest need is really took a data-driven approach. We looked at Medicaid outcomes, understanding who lands in, the bottom quartile of outcomes for their region, looking at what zip codes are actually contiguous, so close to each other, which is why we kind of had this larger Montgomery Chester zone to start and ended up breaking it down further. But knowing that if we have resources that can cover a certain span of area and support those potential interventions, we have both urban and rural communities that we're focusing on across the state. And we really wanted to also focus not just on health outcomes, but where are we seeing poor deprivation statistics, social vulnerability statistics that really show that in case of a disaster, there would be a poor response because of the resource availability, or, there is a high unemployment rate or a high poverty level within these communities. And we also look specifically at racial disparities. So looking at Medicaid measures, where do we really see those health inequities and how can we start to address them? And so, as I mentioned, we did go through this process and ended up with the Norristown-Pottstown zone, in addition to 19 other health equity zones across the state. These slides will be shared with you to take a closer look if you're interested. But really the intent here is to understand that these communities are all of need, but have very different needs. So how can we start to look at potential interventions and really understand that, again, these communities vary in what those needs are. They may have similar underlying drivers as it comes to social determinants of health, but how we actually cater to each community, what resources are available, varies greatly. So we did want to break it down into those specific zones and really start to think about potential interventions and strategies on a zone basis. Any questions there? Please feel free to interrupt me if anyone has any questions. Okay. So again, this will be shared. I know it's a lot of numbers and a lot to take in, but I think it'll be great for this group to have these numbers as well as the next couple slides available. So we did have the support of Oliver Wyman doing some analytics for us early on, and they were able to pull out the zip codes within a contiguous area. So again, this includes Norristown, Pottstown, and the surrounding areas that were looked at. And you can start to see where we're performing poorly, where there are issues and disparities. So these three measures here on the left So percent of patients with diabetes with HbA1c testing, children with primary care visits, and adult with primary care visits, you can see we're actually performing below the Pennsylvania average on these metrics. And so those became the foundation for, we need interventions that will improve these health outcomes. What are those social determinants that may be driving these three poor Medicaid outcomes? And we looked at population health metrics as well as a variety of social determinant of health metrics. And these are now being built upon in our stage currently, which is we've identified potential interventions. Now, how do we build that narrative? What other social determinant of health information and data will really help tell this story? And what can we watch to move the needle on these measures and see our success? So this, again, will be in the shared slides, but really helps provide insight around our needs in housing, food security, things like that are to consider in this space. I will say for this zone compared to others, we see a lot more white space. You know, we saw a lot more of our red boxes for some of the other zones, but it doesn't, it's not reflected always the data of what the community sees. And that's something we heard a lot of from our stakeholders, which is the Medicaid population in these areas also looks a lot different than your average individual. And so how do we start to build that out further? And we did that through work groups and committees who really drove our decision making, helped us understand what our local experts were there to help us understand what we need to be looking at and where do we go from here. Two other quick views. This is one by zip code, how each zip code performs on a specific Medicaid measure. So for example, here, you see that zip code 19401, it performs poorly in adult PCP visits specifically. So we do, it raises a question, is it available services? Are there not enough services in this area? Is it transportation to these services? Starting to think about does it look like? Why are we seeing that adult PCP visits in 19401 are so much less accessed, I should say, than somewhere else in this community? And in the same way, for our health equity view, we did this by race. So where do we see across the zone where are we seeing these health inequities? And I will say the trends you see here are pretty common across the state, where we see that the Black population sees disparate outcomes, specifically in diabetic care and medication for OUD, which is our opioid use disorder. So those two have been really big hitters and where we're seeing inequities across the state, and they are reflected in this zone as well. Any questions about the data before I move ahead?
Julie, this might be helpful for our group here to remind us, or maybe others have this, which are the zip codes for the Pottstown area in this group, so that when we're looking at those zip code numbers, we're matching up.
Absolutely. So let me pull it up so I make sure I say so honestly. I believe it's 19464 and 465 are our Pottstown area, and 19401 is Norristown.
Right.
So in this case, medication for OUD, we see 19465 is performing a little poorly there. I'd say 19464 though is, doing well on this side. Maybe a little improvement needed around ED visits, and maybe that's just because you have an emergency department in that area that's frequently used. So that can be a factor for that measure as well.
Okay. And the index is calculated. What does a -1 or a -2 mean on this scale?
Yeah, so where you see this line going across at 0, this is our Pennsylvania average for each of these measures. So it's all kind of relative to that measure. But where you see above 0, that means we're actually performing better than average in this area. Where we fall below that dotted line, we are performing below average. So that average is based across the entire state, not just our health equity zones, but we do see that our health equity zones all tend to drop below that average when looking at these measures.
Right, I just didn't understand the scale.
Yep,
Minus
so
one, minus
there
two.
was a Z-score, which is a fancy way of kind of saying this is the calculated score based on the average, the kind of differentiator. But I can also provide more specific numbers.
Okay.
I can actually share the data set with the group if that would be helpful. It's publicly available through a really cool tool that I'll share in the chat in a moment.
Got it. So it's something like a standard deviation or two standard deviations. Okay, got it. Some some statistician in the group is going to beat me up over that oversimplification, but got it.
Yeah, absolutely. And so where do we go from here? So we have this data kind of driving our decision making. We have this, our various committees that are helping us understand what are the local needs, where do we need to be focusing our attention. And we will be creating what's called a regional health transformation plan. And this plan will be for the Southeast region with a subsection for this zone specifically. But really the focus here is we will be delivering a plan to DHS focused on what are our health equity zones, such as the Norristown-Pottstown zone. What are the health disparities and social determinants that we're seeing in these areas? What resources are existing, already doing work in this area towards, some of the health disparities or social determinants that we're seeing perform poorly within this zone. And we'll also go on into actually proposing the social determinant of health interventions and potential partners, as well as what are those strategies and milestones to actually measure success as we go forward. And when we do not see the success, maybe we intend to, there will also be a monitoring and rapid cycle improvement strategy. And this will really be a framework to be followed for each intervention. So when we do need to, improve that intervention or expand upon it to see greater success, that framework is available to see that quick, rapid change, as we do intend to change these plans on a year-to-year basis and update them accordingly. Some years, I'm sure it'll just be everything stays the same. Let's just shift this intervention. And other years, it may be we've been really successful in these 3 zones. Let's add another zone or add an additional intervention, and then you'll see some real change. So this initial plan will be submitted to DHS at the end of October and will be available to the public sometime after their review. So that will be available to this group to kind of explore and understand where the council is hoping to go and what those strategies are. And we have kind of a continuous theme across the RAHC of it takes a village. So as we continue to build these plans, really the common theme is how do we focus on collective impact? How do we integrate across our existing silos and really improve the care of our community, the health of our community? And through discussions, there are really 4 key themes that we've identified as necessary next steps to improving that collective impact. And that's focused on education, outreach, integration, and access. Those are our, they're just words, but those are the themes. We need to be able to educate individuals on what's available to them. How can they access services? How can we open those doors from an outreach perspective when there are opportunities? How are we meeting the community where they are to make them aware of those services and opportunities? Integration, really, again, these silos, how do we work together, braid our resources to have that collective impact? And from an access perspective, we're speaking here of cultural competency and the need for health equity. So really focusing on how can that be a focus of every intervention we develop to make sure we're addressing those needs as we go ahead. So that's really, an overview of where we are today in our Montgomery, Chester area. I'm going to jump down here. If you do want to take a look, these are the different measures we've looked at and their definitions, if you'd like to take a look after the discussion. But these are examples of the kinds of interventions we've started to talk about, really focused on social determinants. What is the feasibility? Who may be some key partners within the Norristown-Pottstown area? And what are our goals? And again, this is really high level. These are currently being developed further through what we're calling shared learning forums around social determinants, as well as consumer forums, making sure we have that opportunity for co-production and overlaying the needs and the actual things that a consumer would want to participate in and would want to see in their community. So we are working on that now to really make sure that these interventions are strategized appropriately. These will not all go live right away. This will be a kind of rolling train of success. So starting at the front, we'll likely be looking to initially hold our MCOs accountable to kick things off with an intervention that they all will agree on and really take the momentum to start. As we, funding, resources, those things are all a challenge. And unfortunately, although DHS helped us get started, they aren't promising those things as of now. So really understanding the future of where these other interventions can go is still being explored and developed. So those are really, that's the content I wanted to share with the group today, and then really wanted to provide the opportunity to kind of do a Q&A, answer any questions you may have, and also hear any feedback you may have, anything we should be considering as we go ahead.
Do folks have questions for Julie?
And I do have my email listed in the deck. So if you do have any questions and follow up after you have a chance to review anything in the communication shared following today's meeting, please feel free to shoot me an email. I mean, if you're interested in being engaged at all as well, I'm happy to help arrange that.
Julie, this is Dave Crable. Are there other communities in Pennsylvania that would be in a similar role that we are, that you've noticed that we could compare notes with? This is really a statewide initiative, and in some respects, the success of this moving forward is not just here in Montgomery and Chester counties; it really is across the state. And so I don't know if there are any touch points, maybe in communities our size, or maybe even in counties that might be our size, very frankly, where we could learn from one another.
I'd probably have to look at our list to give a more solid response, just in terms of population and similar needs. But you have set off a light bulb in my mind. Do we partner some of these zones to have shared learning as we go ahead? But I do think, the Norristown and Pottstown communities are unique in that I feel that there are already a lot of organizations working on integration and delivery of care in a way that is focused on the whole person. We see that also in Pittsburgh, we see that in Philadelphia, our urban areas, but once you get out of those kind of urban areas, it is more of a challenge. I think Lawrence County is doing a really good job in that space, as well as Mercer County. And then, I'll say the Northeast is its own little beast. They are a unique section of the state where it's very unique. Allentown, I would also say, is somewhat similar in the integration activities that are already in place. And again, that focus on whole person care. But I'll loop back with you on that to hopefully provide a little more insight based on numbers and alignment on outcomes, et cetera.
So that would be great. And there are a number of post-industrial communities. And in some of those communities, there are, at least from the foundation's perspective, there are either health-related foundations like the Dorothy Ridey Pool Foundation in Allentown, or other conversion health foundations. So we're just kind of curious about that as well. From our perspective, perhaps with the whole group's perspective, but it could be helpful. So, Julie, you go to Las Vegas, and then you go to Washington. What are the chances of this being funded in the future? It's dependent upon the bill we see coming before this omnibus bill, the $3.5 billion that Mr. Machen from West Virginia is going to cut in half. In some respects, I think this is very important, and could be really some unique legislation that could pull some things together. But sometimes financial carrots help, and it seems like we're poised for something here. So. I realize that as a consultant, you may not want to put any percentages to this, and I'm putting you in the spot. but I think for those of us who've been around for more than 1 or 2 decades, sometimes governments come down this road before. But on the other hand, it's like, whoa, here's a unique opportunity where we're really focusing on the neediest communities and being able to work together. So, what do you think?
Yeah, so it's a hard question to answer because there are a lot of unknowns, but I will be as candid as I can be. You know, one of the barriers I can say that I have faced in this role of supporting the programs is the RAHC example of an initiative that was kicked off and went on pause, and now it's unknown. And that happened when we were just getting started with the RAHC program. And that was really a resource and referral tool that the state was looking to implement. And that was going to be a tool that supported this program. So things like that, when they do fall off, it is a big challenge. So I'll preface with that. As far as funding, we do not currently know of any funding that DHS will provide, but we're hoping that the regional transformation plan that we're providing is actually almost a proposal of what we need to be successful. So we do hope to hear more about the potential funding through that. We do have several organizations across the state saying we're really interested in this. You know, we have allocated funding to support initiatives just like this. So we do have some interest flowing in, but there is also the point that the RAHCs are not currently incorporated. So that's also something we're looking to explore as we go further, especially through, you know, as we go through this first year's plan, you know, we are going to have a clear set example of what we hope to do. So if we do incorporate, we have the opportunity to apply for funding to really take these braided resources that we have, distribute those funds, and go ahead in that manner. So it's still an exploratory process in that regard, but I do see, again, that opportunity. As you mentioned, there's a lot that can happen here. And I think that there are a lot of folks who are engaged now, and knowing we have, you know, almost 500 stakeholders across the state. While we have this momentum, how can we keep it going? And I think that's been a really key conversation. I actually have a sustainability discussion with one of our committees this afternoon. So hopefully there will be more to come on that over the next several weeks, probably, unfortunately, months at the pace that we move with things at the state level sometimes. But that's the best answer I have for now. The MCOs will be putting money into this on their own account as we go forward through interventions. But as far as beyond the MCOs, it's still in the gray.
Okay, and I'm guess a really pointed question again. How long is the Prospire contract?
So
What
we
is,
are,
this could be a 2-year effort to get this in place. I mean, I'm just wondering.
yeah, so we are currently only contracted through the end of the transformation plan, but we're already in discussions for what's next. So I know if it's up to Dr. Jacobs, he'll keep PAMCO continue to, you know, support us as long as they can. Knowing that we're making good progress, I think has been really encouraging in the short amount of time. But again, with that momentum already moving, I think it's hoping to capitalize on that and make some quick change, have some quick wins. And then after we see that progress and have the buy-in from folks, we can actually, again, incorporate, get that additional funding and really take things to the next level.
At least for right now, those are my questions. How's that?
Thank you.
Dave, Casey, did you have a question? I saw you come on video and I thought off mute for a second. Did you have something?
No, I don't think I have anything. I've been attending the meetings that have occurred on various topics and the original meeting, sharing this information. All good stuff. Thank you.
Great. So I have one question just in terms of the organizations and participants and how you look at an organization like the TriCounty Health Council. So TriCounty Health Council includes several of the organizations you identified on a prior slide as key resources, key community resources, I think might have been the phrase. TriCounty Health Council itself has been gathering people together, gathering organizations together to do the kind of integrated care, thoughtful breaking down of barriers and better coordination across organizations that that you, I think, appropriately pointed to, and you're preaching to the choir. Literally, the choir is in these little window boxes on the screen, preaching to the choir about the benefit of working together across organization types and services to better serve whole persons. How do you look at an organization like TriCounty Health Council as a resource in the work that you're doing, and what should we be thinking about?
Yeah, absolutely. I think that organizations like this are the future, to put it bluntly. We are seeing in a lot of our communities that organizations like this don't exist, and we already know that's a much greater challenge. Where we already see the integration, that's where we're going to capitalize on those existing, relationships and resources, because we aren't looking to duplicate efforts. We're not looking to reinvent the wheel. We're just looking to help align various organizations and individuals to work towards the same, we're all on different ships. Let's just make it towards the same island. And so where that already exists, we hope to capitalize on that, especially with this organization. When you're reaching out to me, I know it's something I can depend on. So that's already a great sign for our future progress. And I look forward to our continued discussions. But I would say, where we don't see that, we're likely to face many more barriers, and really having to find who will be that backbone organization for these communities to drive change. And that's a real challenge we'll face.
Great. Well, really glad you see it that way, and you value the what we've all learned over the last several years, which is the value of the relationships that are developed and the learning across organizations that lets everyone within their own organizations work better in a more coordinated way with each other. So I'm glad you see that way. That's terrific. Anyone else with a question or comment or thought on that front?
This is Christine Ellis with Creative Health Services. I had a question, just and maybe I missed it, but there was the slide where you had community partners. I didn't actually notice any behavioral health organizations listed, so I didn't know if I missed that. And I was just curious, did you have plans to bring some of those behavioral health folks into the mix with this?
Thank you for that question and for bringing up that point. So we actually, as a facilitator, when Oliver Wyman supported us through our data analytics, we looked at health outcomes as Medicaid outcomes. We looked at population health. We looked at social determinants, and we really didn't look much at behavioral health in that analysis. So it did, drop off a little bit in our purview. And so what we've actually done is, we consider behavioral health as it equates to any kind of health. If we're looking at a health system, we are equally looking at the behavioral health services in that community, because that is what we're hearing from our stakeholders is a key driver to social determinants. Those with mental health issues or concerns, how do we better support them, and how do they, if we can successfully support that community, we have a model that will work for our larger community. Those do tend to be our most vulnerable and complex cases. And they're also, that continuum of care. How do we make a more comprehensive view of social determinants? So they aren't listed as specific resources for those interventions, because those are all focused specifically on that social determinant domain. So if it's food security, it's a lot of food pantries, distributors, et cetera. And we are really keeping that behavioral health resource list separate, as they will be key to any of these interventions as we go forward.
Thank you.
All right, well, I know my time is up here, but I really appreciate the opportunity to meet with you all today. And please, of course, feel free to shoot me an email if you have any questions. And I hope you all have a great rest of the day.
Thanks, Julie. Really appreciate it.
Thank you.
Thank you, Julie.